head's not in it?
No, I think it's okay. Okay, so I have Kristen with me, who's an NP. So tell me about yourself.
So my name is Kristen. Do you think it's going to be over here as for me?
I'll turn the volume on.
Okay. And I have been an NP now for just over a year. And I was a GI nurse before that, and an oncology nurse before that. And then before I was a nurse, I was a dietitian and a high school teacher and all sorts of things.
So can you describe your position and like what specialty you're in?
Sure. So I am an NP at Metro. I work in medical oncology, and I specifically do breast cancer. Almost exclusively breast cancer. I've become kind of the breast cancer expert, actually.
So do you see any advanced practice nurse influence in today's healthcare system?
I do. Not enough, but I do. You know, there's a big need to fill some gaps, and those gaps, at least in oncology, are when patients are being treated in an active chemotherapy and they need toxicity checks, for example, before their treatment to make sure that they are tolerating their prior cycles of chemo. And so that's where I seem to fill in a lot of gaps. There's kind of two different arms to it. One is I fill in the APNs, at least or APPs in my department, fill in that gap where we see people before toxicity checks to make sure that they're candidates for treatment and evaluate their labs. And then the other group of people that I see are the long-term surveillance people that are every 6 months or once a year and are just there after having a mammogram and they just need a breast exam and to make sure that they have not had a recurrence.
Okay. So what are some barriers that you face?
It's a loaded question. Right?
Yeah.
It's a loaded question. So really the big one, there's one ginormous one, and it's that I don't think that the medical world, specifically MDs, know how to use us effectively. I think that I'm really lucky in that the doctor that I work primarily with basically gives me free reign to do whatever I want and order whatever I want and manage my patients. However, she's sort of the anomaly, not the norm. Most of the physicians that I have come into contact with that have an APP, whether it's an NP or a PA, they micromanage them to death. And it's really frustrating. There's one particular girl that actually left and went to a different hospital because of that. Like, she had to get every order cleared with her doctor and every scan cleared and all, and not only that, but our license allows us to practice independently, not with full authority. You still have to have a collaborating agreement, but besides the collaborating agreement, I can do whatever I want. I can completely manage my own patients, and I don't need to go running back to my physician to get clearance for anything. There's also, as a barrier, there are still a variety of tests that are kind of higher level tests that are only MD authorized. A lot of it's like genomic testing that is becoming much more common in the cancer world, where we send in lab samples of the patient's actual biopsy of their tumor and they analyze it to see what specific treatment will benefit that person, kind of like a Know Your Tumor program. But those tests I'm not allowed to order as an NP. They have to be ordered as an MD. Just things like that. Like if I don't know, I'm going to go ask someone. But if I do know, don't waste my time and theirs by making me jump through these 47 hoops. And I think that we are still not paid what we want. Not for the amount of work I do. I am not paid nearly enough.
So I guess this goes along to the changes that you would like to see made for.
So I think that the pay is one. I mean, people can make more money as an RN working as a travel nurse or something than I make as an NP. But I think the biggest thing is we really need full practice authority in the state of Ohio. And there are like maybe 17 states or so that have full practice authority, and there are ways that people get around it in Ohio. But we need that in order to be able to do what we need to do.
Right.
And I think that the changes that I see needing to be done are really at government level. There's a lot of changes that need to be made at a local level, meaning within even a hospital, and teaching docs what we can do and how to use this effectively and whatnot. But I think the big changes that need to be made are at the big level, where you can lobby and whatever, but it's all slow and it's cumbersome, and it's hiring, and it may or may not ever happen. So I think there's lots of changes.
All right. Well, thank you, Kristen.